My name's Dr. Paul Chadwick. I'm a consultant podiatrist at Salford Royal and also a visiting professor at Birmingham City University. It's a great honour to be asked to chair this session today. We've got a great symposium for you. I'm sure you'll be excited by the symposium and the product that we're going to discuss today. We've got Kim Wilde, who's an advanced podiatrist from Manchester Foundation Trust. And I'll introduce Kim a little bit more when she comes back on later. And Ingrid Chavalon, who's a scientific product manager at Woulgan. I'd like to thank H&R Healthcare and Biotech for sponsoring this symposium. My first job, as well as being chair and keeping people in order and making sure you ask lots of questions, is to go through what are the key challenges in wound care in 2018. And people who've heard me speak before, I do like my jigsaws, so I put it into jigsaws, try and pull all the bits together. Look at the sort of top right here, we've got healthcare professional education. And we think about the education now in 2018, where we've got loss of bursaries, we've got an impact on undergraduate education, we've got people not coming through the system being educated in wound care. A lot of the wound care education is very much about who you get to be sat with in undergraduate, you know, which district nurse you went to, which placement you were on, which ward you were on. Exposure to wound care differed from where you were placed in practice. And that continues as you go through practice. So healthcare professional education is a significant problem. Societal factors are also something that a lot of people don't consider. How do we make people come to our appointments? What is health-seeking behaviour? What drives people to the attention of practitioners? If we link that together with access factors and the area of specialty that I have, which is around the diabetic foot, we've still got 38 hospitals in England alone that have no access to an MDT. So if you've got a diabetic foot ulcer in those areas, you can't access the services that you require. And then we think about patient factors. We've got this growing demographic of an aging population with lots of comorbidities, this tsunami of diabetes, all these things pulling together to make a significant problem in terms of wound management. Central to all this is the risk of health economics and the problems around the economics of wound care. We know from the global cost of wound care that around £2.9 trillion is spent on wound care globally. We also know that there's never been a more pressing need to address this global epidemic, this global tsunami of wound care that's going on nationally and internationally. And if we focus down on the national problem, and I'm sure everybody's been to any symposium today, there's been at least one mention of the Julian Guest paper. I was sat with Julian Guest at a meeting in Amsterdam about 2 months ago, and we're discussing this in great detail, and he showed some really interesting data about product use and how people tend to sort of almost ritually move from one product to another without actually thinking about what the problem is and why the wound's not getting better. But we think about that £5.3 billion of NHS spend in England alone, and that's not too bad if we think £5.3 billion being spent on healing wounds. But when we break it down, around £3 billion of that is spent on not healing wounds, just treating wounds, ritualistically, putting a dressing on, sending them away. £3.2 billion is a massive amount. Which is why we've got this new wound care strategy that's been introduced across England to try and address some of those problems. So when we think about wound care, and if you're a purchaser or a provider or a payer in the audience, what you probably think about is the cost of dressings. You probably think this is the most important bit in terms of what the cost of wound care is. But in reality, wound care is nurse time and hospitalisation and inappropriate management. So we've got this whole episode where people are misdiagnosed, picked up late, hospitalised and managed ineffectively, and that accounts for 50% more of the total cost. If we think about the other elements I talked about lack of systems of care, you've got lack of access to specialities of MDT. I've already touched on this today where we talk about this access to tissue viability services now are being under pressure, access to podiatry is under pressure. It was really interesting when you look at the Guest paper, the cost of the podiatrist for the annual figure was something about £40, and that doesn't indicate that podiatrists are not the people that should be treating diabetic foot ulcers. It's just that they're not referred to podiatrists or there's no access to podiatrists. And we've also got this issue of lack of MDTs. There's no movement up and down a care escalator, so in wound care you should be escalated up when you've got significant complex problems and escalated down, but quite often people get held in primary care or get held in secondary care inappropriately. I used to be really proud working in the NHS about the openness and the transparency, and certainly stuff like the Francis report, which made us think about the work that we were doing around causing harm to patients. And that really should be a positive thing, but you're starting to see that creep back in now where we're doing root cause analysis and there's actually that blame culture where it's your fault. It's not about faults, it's about expanding and exploring what's going on in terms of what happened when there was an adverse outcome. But often it's turned into a blame culture, so people are reluctant to come forward and reluctant to refer because of that feeling of blame. Personalities. One of the biggest issues in change and management of movement up and down is personalities. People like their own little status quo. So if you've got your person who doesn't want to see that patient or quite likes seeing those patients, then you get these people stuck in systems of care and not move through them quickly. Lack of education, I've already touched on, where we've got this people being too busy actually doing the patients to educate the other people who might prevent those patients coming to them, and also too busy doing other things like talking at conferences. And then you have people like a vested interest. And this is a good example of this is people who work in secondary care potentially who might be getting a significant tariff for dealing with that patient in secondary care, where it might be more appropriate if that patient was passed down to primary care, where the tariff feels lower, and those resources can be redistributed to other cases. So we have this scenario where we've got people working very hard on the patient, but actually not joining the dots up, and actually the patient's getting no benefit. If we look at diabetic foot disease, which again is my speciality, we need to consider the 5 elements of treatment. So we think about pressure relief and debridement, which is what we take off the foot, wound management, which we'll focus down on in a little bit, and holistic assessment, looking at the patient as a whole, looking at their vascular supply, looking at their diabetes control. And if we're looking at different wounds, we might be looking at their venous return, etc., and looking at the patient as a whole, depression, all these elements that impact on a patient's wound healing. And we keep the wound clear of infection, and we've got the opportunity of taking that wound into a healing trajectory. So we pull all those bits of the jigsaw together. We've got debridement there, we've got offloading ROM walkers, we've got a patient there with a really infected foot. That's not a foot that's got ischemia, that's infective changes as a result, that's gangrenous changes as a result of infection. We've got wound dressings, and we've got management of the control. So focusing down on those elements and thinking about these principles of local management and how we manage these wounds as we move forward, standard DFU management should involve all those key areas. That's good standard care, good standard control. If after 4 weeks of good care, there's not been a 50% reduction in the wound size, that wound is unlikely to have healed at 12 weeks. And that's a key point in the wound healing journey. If we've not, certainly in the diabetic foot, if we've not got that 50% reduction at 4 weeks, then we need to consider other therapies or additions to standard of care. It's really key, and we talk about measuring quite a lot, but it's really key that we do measure our wounds and assess the wounds effectively. We need to know whether that wound's stuck, stalled, going backwards, or indeed improving. And as I will reiterate, a critical interval is 4 weeks after treatment is initiated. So I'm going to talk about a tale of 2 cities just to finish off. As you can see, people who know the area, the one on the right is Salford, although you probably wouldn't notice that. It's just because the gondola's missing you, that's why you don't recognise it as opposed to Venice, I'm sure. Anyone in Salford, yeah? I did have a better picture than that, but it made me take it out. But that's Salford, and that's where I work. And there you've got another city on the other side, which is Venice, obviously. Both nice cities, both different. If you look at these 2 cities as a separate entity and look at them as having 100,000 population, one using standard care, so we say Salford's using standard care and Venice is using Woulgan as an adjunct with standard care. And then we've done a cost analysis based on this, looking at the prevalence and treatment costs taken from Julian Guest's paper in 2015. And then we've also used a paper which Ingrid's going to talk about, which is the healing rates taken from Sharon Hunt's paper, which was published in the Journal of Wound Care in 2018. We take Salford, the standard care city, around 46% healing rate in 24 weeks, and the patient's healed and happy. And nobody's happy in Salford, I have to tell you that. They don't see enough sunshine. Around 557 patients. Total cost of the population, about £3.25 million. If we look at Venice and the Woulgan care city, we start to see a significant difference compared to the standard care. So all we've done in these patients is add in Woulgan. At that time, we get a 92% healing rate in 24 weeks, and healed and happy, and they're probably a lot happier if they live in Venice and they go down the gondolas and they get married and get people serenading them anyway from living in Salford. But there's 1,131 patients who are healed and happy. And if you add that together in terms of costs, we've got this thing now where we're looking at about £1 million worth of savings based on the addition of an adjunctive therapy. There's been a recent Women's UK publication which are now starting to advocate the use of Woulgan very earlier than this 4-week period. So this is probably something we should be starting to debate around, whether we should start to use this product earlier on in the treatment cycle rather than waiting the 4 weeks. But hopefully our presenters will expand on that later. And thank you very much for listening to me.